Hi, sir. Hi. So, good evening to all of you. Okay. So, let us begin with the anatomical PYQs. So, high yield PYQs have been selected for you. So, let us discuss this and simultaneously we cover the important topics as well, which can be asked as MCQs. Okay. So, let us begin. Are you all ready? Be interactive. Keep on answering. Let it be an interactive session. Okay. So, here I begin with the first MCQ. Have a look at this. Identify the type of papillae shown in the microscopic picture of the tongue. We know the dorsal aspect of the tongue, which is divided into anterior 2/3 and posterior 1/3 by a V-shaped sulcus. What is that sulcus known as? The sulcus terminalis. And at the apex of the V, what do we have? The foramen cecum. Correct? The anterior 2/3 of the tongue is rough, shows a number of small projections which are known as papillae. Right? So there are four types of papillae: filiform, fungiform, foliate, and circumvallate. Out of which, this is the largest papillae, and this is the circumvallate papillae. Very good. That's a circumvallate papillae. Excellent. That's a circumvallate papillae. And what is the characteristic of the circumvallate papillae? It has got taste buds in it, right? It has got taste buds. The circumvallate papillae. What is the epithelium of the tongue? It's stratified squamous, stratified squamous, mainly epithelium, right? The posterior 1/3 of the tongue shows lymphoid tissue. It acts as lingual tonsil. That is known as lingual tonsil, the posterior 1/3 of the tongue. If we try to understand this specific structure of this papillae, okay, circumvallate papillae lies in front of the sulcus terminalis. And how are they? They are cylindrical in position, and there's a trench, right? They're surrounded by a sulcus. Like if this is a circumvallate papillae, there's a sulcus here. You can see this. There's a sulcus around it. There's a trench around it, and they've got taste buds here. Taste buds. So lies in front of sulcus terminalis. We have got the fungiform papillae, which are mainly present on the tips and the margins of the tongue. A small pedicle. Fungiform. Yes. This has got a pedicle and a rounded head. So this is the rounded head, and it will be having a pedicle like this. It is bright red in color. Filiform papillae are present in the presulcal area, small and numerous, covered with keratin. Okay, so the epithelium is going to be stratified squamous keratinized, and foliate papillae are less in number. Right? So clear with this? The first MCQ. Okay, just quickly revise the nerve supply of the anterior general sensations. Come on, you can answer this. Anterior 2/3 general sensations is going to be by. So we divide the tongue into anterior 2/3, the posterior 1/3, and the posterior most part of the tongue. Anterior 2/3 general sensations is lingual nerve. Yes. And special sensation is, yes, Devang, come on. Drug of choice, answer this. Special sensations in the anterior 2/3 is the chorda tympani, which is a branch of facial given in the middle ear. Correct? Posterior 1/3, both general and special sensations are supplied by glossopharyngeal nerve. Correct? And the posterior most part of the tongue. Yes, answer this. Nerve supply of the posterior most part of the tongue. Come on, Bacho, be interactive. Let it be an interactive session, so we'll be able to discuss many things here. Posterior most part of the tongue. Be very specific. 10th, no. 10th is fine. Which branch of vagus are you talking about? Which branch of vagus is that? Yes. Vagus. The posterior most part of the tongue is derived in the fourth pharyngeal arch. Come on. What is the nerve of the fourth arch? So, which is that branch of vagus which is going to supply it? Any guesses? The nerve of the fourth arch is superior laryngeal nerve, right? Nerve of the fourth arch is superior laryngeal. So a branch of superior laryngeal is going to supply the posterior most part of the tongue, because that is the part of the tongue which is derived from the fourth pharyngeal arch. It is the internal laryngeal nerve. You know, bacha, the superior laryngeal divides into an external laryngeal and internal laryngeal. This internal laryngeal nerve is going to supply the posterior most part of the tongue and epiglottis. Correct? This internal laryngeal nerve also supplies the sensory supply of the larynx above the vocal folds. Above the vocal folds. That's internal laryngeal. What is the external laryngeal nerve supply? Any guesses? What is the external laryngeal nerve supply? So there are plenty of MCQs which gets covered here. What is the external laryngeal nerve supply? Come on, come on, come on, students, come on, answer this. This you must be knowing, I'm definitely sure. Bolo, bolo, bolo. I'm looking at the screen, I'm waiting for your answer. The external laryngeal nerve, what does it supply? Cricothyroid muscle. And this cricothyroid muscle is a tensor of the vocal cords. Tensor of the vocal cords, that's cricothyroid. Clear? So that completes the nerve supply of the tongue also. Anterior 2/3 of the tongue is derived in the first pharyngeal arch. So the nerve is lingual nerve. Special sensations are by chorda tympani. Posterior 1/3 of the tongue is derived from the third arch. So the nerve is glossopharyngeal nerve. And the posterior most part of the tongue is derived from the fourth arch. The motor nerve supply of the tongue is hypoglossal nerve. Hypoglossal nerve. And students, can you tell me what is the component required by the hypoglossal nerve to supply the muscles of the tongue? What is that component? You know, you must be knowing the component: general somatic, special somatic, general visceral efferent, general, yes. So what is that component which is going to supply the muscles of the tongue? It's the general somatic efferent component. That's a general somatic efferent component which is going to supply the muscle of the tongue, and this muscles of the tongue and the extraocular muscles are derived from the occipital myotomes. Occipital myotomes. Okay, students, be there. So yes, so there are many things which we'll be discussing here. We won't remain confined to that MCQ. We'll discuss everything around it. Perfect, bachcho. And can anyone tell me what is derived from the foramen cecum? From the foramen cecum of the tongue, here there's a foramen cecum. From this foramen cecum, something goes down. That's a thyroglossal duct. Later, this thyroglossal duct obliterates off, disappears off. This thyroglossal duct will divide into two lobes of thyroid. This thyroglossal duct, if it does not regress, it results in a thyroglossal cyst, sinus, or fistula. Perfect. Okay. Next MCQ. Answer this question. A 30 years old male or old patient complains of diminished vision on the right half of both the eyes. Where is the most probable lesion? Come on, answer this. Any guesses? Right half of both the eyes. Right half of both the eyes. So it is a contralateral homonymous hemianopia. Right half of both the eyes. Correct now? So it's a contralateral homonymous hemianopia. So where do we get this? It's the left optic tract. Excellent. Drug of choice. Very good. It's the left optic tract. Let us understand this lesions of the visual pathway. Yeah. So that's the visual pathway. These are the nasal fibers, and this, I mean, the fibers coming from the nasal field of vision. This is the temporal field of vision. Okay. So this is the optic nerve. If the optic nerve is damaged, there's going to be a complete blindness, right? A complete blindness here if the optic nerve is damaged. What is this? This is damage to the optic chiasma because of pituitary tumors. The optic chiasma gets compressed. What do we get? So nasal fibers coming from the nasal, so the temporal field of vision is gone. So this is a bitemporal hemianopia. The lesions of the optic tract are going to cause what? A bitemporal hemianopia. Coming down, if there's a lesion of the optic tract. So temporal fibers of this side. So which field of vision is lost? Nasal field of vision for this eye, and the nasal fibers from this side. So temporal field of vision for this eye is gone. So we get a temporal field of vision for this eye, and nasal field of vision is for this eye is gone. So this is a contralateral homonymous hemianopia. So contralateral homonymous hemianopia is due to involvement of the optic tract. Correct? Now there are some fibers of the visual pathway. When they go towards the occipital lobe, they pass through the temporal lobe. They are going through the temporal lobe, and this is what we call as the Meyers's loop. So damage to the Meyers's loop would result in a superior quadrantic anopia. A superior quadrant is gone. So damage to the Meyers's loop, the fibers of the visual pathway which goes from the temporal lobe, that's the Meyers's loop. And damage to this Meyers's loop is going to cause a contralateral superior quadrant anopia. Okay. The fibers of the visual field, if they are damaged, it results in a contralateral inferior quadrangle. Okay, and if there's a lesion of the visual cortex, if there's a lesion of visual cortex, what will happen? There'll be a blindness with macular sparing. Blindness with macular sparing. Students, can you tell me what is the blood supply of the occipital lobe? The blood supply of the visual cortex. Anyone? Blood supply of the visual cortex. Answer this MCQ. Blood supply of the visual cortex. Yes, very good, very good, very good. The blood supply of the visual cortex is going to be the posterior cerebral artery. Yes, the posterior cerebral artery is going to supply the visual cortex, but there's some other artery also involved. So if there's a thrombosis of posterior cerebral artery, there's blindness with macular sparing. So which is the other artery which is going to supply the visual cortex, which is going to supply the macula? Macula. MCA. So blood supply of visual cortex, if it is asked, it is PCA plus MCA. PCA plus MCA. The entire visual cortex is supplied by posterior cerebral artery, and the macula, which is for fine vision, that is supplied by middle cerebral artery. Okay, so blood supply of visual cortex comes as an MCQ. Your answer is PCA plus MCA. Correct? Fine, students. Can anyone tell me what is the blood supply of the motor area? Come on, blood supply of the motor area. Blood supply of the motor area. Any guesses? Come on. Blood supply of the motor area. So we discussed the blood supply of the occipital lobe. Anyone? Can anyone tell me what is the blood supply of the motor or sensory area? Motor or sensory, anything is fine. This blood supply of the motor area or sensory area. Any guesses, bacho? Come on. See, if I draw this surface of the brain as the supralateral surface, look, if I draw this as the supralateral surface of the brain, this is the lateral sulcus, that's the central sulcus, right? This is the precentral and that's the postcentral sulcus. So that's the motor area, that's the sensory area. You tell me now, what is this artery which is present in this lateral sulcus? Answer this. What is the artery present in the lateral sulcus? Artery present in the lateral sulcus. That's an MCQ, bacho. That's an MCQ. Come on, if you can answer this. Artery present in the lateral sulcus, and if I draw a slide like this for you, that's the corpus callosum and that's the surface of the brain. So which surface of the brain is this? The medial surface of the brain. And what is this artery present in the callosal sulcus? Come on, answer this, bacho. Very good, Jasmine. Very good. So the artery present in the lateral sulcus is middle cerebral artery. Very good. So this is the middle cerebral artery. Okay, that's a very, very important MCQ to be remembered. Artery present in the lateral sulcus is middle cerebral artery, and the artery present in the callosal sulcus. Can anyone tell me this? Artery present in the callosal sulcus is anterior cerebral artery. That's the anterior cerebral artery. Perfect. Now, this entire medial surface, students, this entire medial surface is supplied by whom? The anterior cerebral artery. The entire medial surface would be supplied by anterior cerebral. The anterior cerebral also goes to that side. That side meaning the lateral side. A small area on the lateral side, on the supralateral surface, is supplied by what? Anterior cerebral artery. A small area on the supralateral surface is supplied by anterior cerebral artery. The major part of the lateral surface is supplied by whom? Middle cerebral artery. The middle cerebral artery also supplies this part of the temporal lobe, and the occipital lobe is supplied by whom? The posterior cerebral artery. Occipital lobe is supplied by posterior cerebral artery. Yeah. So the artery present in the callosal sulcus is anterior cerebral. That's a very, very important MCQ for you. Artery present in the lateral sulcus is middle cerebral artery. So now if I tell you if I ask you what is the blood supply of the motor or the sensory area, yes, now you answer. Yeah, this PYQs are there, bacha, but with this PYQs we discuss the other topics also. So the many concepts which will be cleared. ठीक है ना? वैसे concepts ही होते हैं वो which are asked in different ways in the MCQ. So what is the blood supply of motor area or sensory area? बच्चा, drug of choice, two arteries. Two arteries. The blood supply of the motor or the sensory area will be two arteries. No. Nahin. Look. This much part would be supplied by whom? This much part would be supplied by middle cerebral artery. And this part would be supplied by whom? The cerebral artery. So blood supply of the motor or the sensory area, your answer is going to be MCA plus ACA. Okay, it's MCA plus ACA. Both. MCA and ACA. Just remember, huh? These are very important MCQs. Very good. So clear to all of you. And blood supply of the visual cortex is PCA plus MCA. PCA plus MCA. Perfect. Clear? Any doubts here? Artery present in the callosal sulcus, ACA. Artery present in the lateral sulcus is MCA. MCA. Very good. Chalo, let us go to the next MCQ. Answer this. Patient presented with history of vision loss. On investigation, an aneurysm was identified causing compression on the optic chiasma. Which of the following artery is most likely to be involved? Yes. Okay, can anyone answer this? Answer is anterior communicating artery. वैसे aneurysms are there in most of the arteries, but if there's an aneurysm in the anterior communicating artery, it is going to compress on the optic chiasma. Okay, anterior communicating. Very good. Abhirami. Yes, Abhirami. Yes. So let us discuss something, and that's anterior communicating artery. Yes. So you quickly tell me, Bachcho, what is this that I'm drawing now? That's the internal carotid artery here. This internal carotid artery is going to divide into a smaller anterior cerebral artery, and this is going to be a continuation of internal carotid. That's the middle cerebral artery, right? A smaller anterior cerebral artery and a larger middle cerebral artery. So who's a continuation of internal carotid artery? That's the middle cerebral artery. Another very important MCQ. So if there's a thrombus or a clot in the internal carotid artery, which artery is the clot going to be in? Middle cerebral artery, right? Because middle cerebral artery is a continuation of internal carotid. Perfect. Now you tell me, Bachcho, what is this artery? These are the two vertebral arteries. These two vertebral arteries will join to form the basilar artery. And what are these branches of basilar? The terminal branches of basilar, that's the posterior cerebral artery. Posterior cerebral. What is this branch of internal carotid? This is the posterior communicating artery. And what is this branch of anterior cerebral? That's the anterior communicating artery. Okay. So this becomes the circle of Willis. Clear now? You must be knowing this circle of Willis. So that's the internal carotid artery, anterior cerebral, anterior communicating, that's the vertebral artery, that's the basilar artery, that's the posterior cerebral artery, that's the posterior communicating artery. So which is the artery which does not participate in the formation of circle of Willis? Come on, can you answer this? Which is the artery which does not participate in the formation of circle of Willis? That's a very important MCQ which has been asked many times. Come on, answer this. This becomes the circle of Willis. Yes, the artery which is not involved in the formation of circle of Willis is middle cerebral. Excellent, Bacho. Very good. That's a middle cerebral artery. And this circle of Willis lies somewhere. Can anyone tell me where does this circle of Willis lie? It lies in an area of brain. What is that area of brain? Come on. That's another MCQ for you. See, I'll just draw this for you. That's the optic nerve. This is the optic chiasma. That's the optic tract for you. Okay, that's the optic tract. Just one moment. Now you tell me what is this part of the brainstem? That's the midbrain here. That's the midbrain, crus cerebri. That's the pons, and that's the medulla. These are the pyramids here. These are the olives here, and that's the inferior cerebellar peduncle. Now, if I draw the brain here, see, I should be able to draw. No, not being seen here. Okay, this is seen. So what is this surface of the brain that you're looking at? Come on, bacho, can you answer this? What is the surface of the brain that you're looking at? No, this is not the clivus, bacha. No, this is not the clivus. No, no, no. It doesn't lie on the clivus. What is this surface of the brain that you're looking at? That's the inferior surface of the brain. And what is this part of the temporal lobe known as? Which I'm coloring that for you. Yes, inferior surface of the brain. And what is that? Hidden part of the temporal lobe known as insula or the insular cortex. Fine, very good. I just want you to understand what is this area. Look at this. I'll highlight this for you. This is the optic tract, anterolateral, and this is the crus cerebri, posterolateral. What is this? What is this area known as? Come on. What is that area known as? And this is the area where the circle of Willis is going to lie in. Any guesses? Any guesses? What is this area known as? Come on, students, come on. You can answer here. Even if you make mistakes, that's okay. So what is this area? This is what we call as the interpeduncular fossa. Interpeduncular fossa. This circle of Willis is going to lie in this interpeduncular fossa of the brain. And what are the boundaries of this interpeduncular fossa? Anterolaterally is the optic tract. Posterolaterally is the crus cerebri. The floor of this interpeduncular fossa is formed by the pituitary stalk here, the mammillary bodies here, and the posterior perforated substance. The pituitary stalk, the mammillary bodies, and the posterior perforated substance. And what are the contents of the interpeduncular fossa? The contents of the interpeduncular fossa are going to be what is this nerve? Any guesses? What are the contents of interpeduncular fossa? This is the third nerve here. Oh, just one moment. That's the third nerve and the circle of Willis. This is the interpeduncular fossa. The content becomes the third nerve and the circle of Willis. Am I clear to all of you? So that's the circle of Willis. It lies in the interpeduncular fossa. I told you how the circle of Willis is formed, which is an artery which does not contribute to the formation of circle of Willis. What is interpeduncular fossa? What are the boundaries, the floor, and the contents of the interpeduncular fossa? Hope this is clear to all of you. So the answer here for this MCQ is anterior communicating artery. So that's the anterior communicating artery aneurysm, which is a very common aneurysm of anterior communicating artery. Okay, students, can anyone tell me what is this artery? Come on, answer this. If you get this as a visual slide, you should be able to identify this artery as well. What is this artery? Come on, bacho, come on. Answer this. What is this single artery? If I give one more hint, it will be very easy. Any guesses? That's the anterior spinal artery. Yes, we'll come to this. Just wait. So what is this? Anterior spinal artery, and anterior spinal artery is a branch of vertebral artery. Vertebral artery gives anterior spinal, posterior spinal, and posterior inferior cerebellar. Posterior inferior cerebellar artery. Fine, clear to all of you? Okay, we'll come to that question as we discuss the nerves. Clear to all of you? Tell me, labyrinthine artery is a branch of labyrinthine. Labyrinthine artery is a branch of. Come on, answer this. Labyrinthine artery is a branch of. That was an MCQ which was previously asked. Till now we used to say labyrinthine artery is a branch of basilar, right? Till now we used to say labyrinthine artery is a branch of basilar, but recently it has been shown it's a branch of what? Any updates on this? Anterior inferior cerebellar artery. Remember this, labyrinthine artery is a branch. Now it is said to be a branch of anterior inferior cerebellar artery. If anterior inferior cerebellar artery is not in the options, take it as vertebral. Take it as basilar. Basilar artery. Okay. So labyrinthine artery, your first answer would be anterior inferior cerebellar artery. If this is not in the option, take the option as basilar artery. Okay, just remember all this, bacha. Remember all this. Right? Internal carotid is fine. Okay, we'll go to the next MCQ. Come on, students, can you answer this MCQ? A patient has undergone submandibular gland excision and the Wharton's duct, that's a submandibular duct, was ligated in this process. Which of the following nerve is most likely to be damaged during the process of ligation of the duct? Any guesses? Now, this is a very important MCQ and the options are equally very important. This option can come in some other MCQ, so you need to know this options very well. Yes, what is the answer? Nahi bacha, nahi. Answer A nahi hai. Drug of choice. Answer is not A. No, no, no. No, I'll just show you one slide. Now, ek minute, just wait. Look at this slide. And this is beautiful. This is beautiful. Can you identify this? Come on. If this comes as a visual slide, bacha, you should be able to identify this. Can you tell me what is this A? What is this A structure? What is this B structure? What is this C structure? And what is this D structure? And what is this E structure? Come on, if this comes, I mean, what is this? This is the oral region. Oral region. This is the oral region. What is A? Abhirmani, very good. Abhirmani, very good. A is lingual nerve. A is going to be the lingual nerve. A is the lingual nerve. What is B? Can anyone tell me what is B? So I'll just mention this for you. A is lingual. Okay, this comes as a visual for you. So you have to know this. What is B? What is hanging from the lingual nerve? Can anyone tell me what is this? Something which is hanging from the lingual nerve, which lies on a muscle. B is the submandibular ganglion. B is going to be the submandibular ganglion. This you should know, but this you should know. This is extremely important. Be very clear about this. What is hanging from the lingual nerve is the submandibular ganglion, and this submandibular ganglion is lying on which muscle? Can anyone tell me what is this? What is this starred muscle that I'm showing you? What is this muscle here on which the submandibular ganglion is lying? This muscle is the hyoglossus. This muscle on which all these structures are lying, that muscle is the hyoglossus, bacho, and this hyoglossus is therefore known as the key muscle of the oral region. Key muscle of the oral region is hyoglossus. Remember, we normally know only one key muscle, right? The key muscle of the gluteal region. Yes, we know this. Can anyone answer this? Key muscle of the gluteal region. Come on. Key muscle of the gluteal region. I'm jumping from one topic to the other, but you should be able to understand this. Key muscle of the gluteal region. Any guesses? 𝐂𝐸𝐻, 𝐂𝐸𝐻. Key muscles are very important muscles. The moment we get this muscle, you get everything in this region. Like you get the key to a room, you get everything in the room. So key muscle of the gluteal region is piriformis. I hope you know this. Key muscle of the gluteal region is piriformis. Key muscle of the infratemporal fossa. You know this, bacha? Or I'll write this down. I'll just write this down for you. You should know this. Key muscles. Key muscle of gluteal region is piriformis. Because the moment we get piriformis, we get everything in this region. We get the sciatic nerve, we get superior gluteal nerve vessels, inferior gluteal nerve vessels. Key muscle of the infratemporal fossa. Any guesses? Infratemporal fossa. The moment you remove the mandible, that area is the infratemporal fossa. And if I get a muscle here, I get everything in this area. I get the lingual nerve, I get the inferior alveolar nerve, I get the branches of the mandibular nerve. That is the lateral pterygoid. Okay, so key muscle of the infratemporal fossa is lateral pterygoid, and key muscle of the oral region is hyoglossus. Hyoglossus. Because now you'll see there are many structures which are lying on the hyoglossus. Let us understand this. Hyoglossus. Okay, that's a key muscle of the oral region, hyoglossus. Have a look at this. Right. So that start structure is hyoglossus. What is D, bacho? Can anyone tell me what is C? C for that matter. What is C? C is the hypoglossal nerve. C is the hypoglossal nerve. E is the submandibular gland. E is the submandibular gland. Can anyone tell me what is E? E is a nerve. E is a nerve, and this nerve is going deep to the hyoglossus. This nerve is going to supply the sensations to the palate, and it also supplies the posterior 1/3 of the tongue. What is that nerve? E is going to be the glossopharyngeal nerve. Glossopharyngeal nerve. I hope this is clear to all of you. All the structures are clear. Yes, bacho. Yes, Abir Mani. Yes, KK. Tug of choice. Jasmine. Anyone else is here, bacho? Very good. Yeah. So this tarred muscle is the hyoglossus. And can anyone tell me what is this F? This F is the submandibular duct, Wharton's duct. Wharton's duct. So we are excising the submandibular gland, and we are removing the submandibular duct. And while removing the submandibular duct, accidentally a nerve gets damaged. This is the nerve which is going to wind around the submandibular duct. It is going to loop around the submandibular duct. Yes, that's the lingual nerve. Lingual nerve. I hope this is clear to all of you. Inferior alveolar nerve doesn't come here, bacha. Inferior alveolar nerve enters the mandibular foramen. It enters the mandibular foramen. It supplies the lower jaw, lower teeth, and it emerges out from here as the mental nerve. Mental nerve. That's the inferior alveolar nerve. So inferior alveolar nerve not here. Okay, I hope this is clear. Yes, can anyone tell me? Is this clear? So I'll proceed. Any thing which is not clear? Okay, bacho, you tell me what is this muscle? If this comes as a visual slide for you, suppose, and if this muscle is pointed, now this is the muscle which is the what do I say? It is the safety muscle of the tongue. This muscle is the safety muscle of the tongue because this is the muscle which is going to protrude the tongue. Come on, answer this. This is the muscle which is going to protrude the tongue, and this muscle is going to form the main bulk of the tongue. Main bulk. Yes, come on, bacho, come on. Can you answer this? The main bulk of the tongue is formed by which muscle? The muscle which helps to protrude the tongue. The muscle is therefore known as the safety muscle of the tongue. If this muscle is paralyzed or if a person is unconscious, this muscle, the tongue falls back and the person dies. So this muscle is very important to maintain the breathing passage, a patent respiratory tract. What is this muscle? Come on. You must be knowing this. This is the 𝐒𝐿𝐴𝐿. Glossus. Head and neck is very important. Plenty of MCQs on head and neck would be there. So be very clear about the head, face, and neck along with neuroanatomy. Okay. So the safety muscle of the tongue is genioglossus. Remember, the safety muscle of the tongue is genioglossus. And what is the function of genioglossus? It is going to protrude the tongue, and this genioglossus is going to protrude the tongue to the opposite side. Remember, so the right genioglossus is going to protrude the tongue to the left side, and the left genioglossus is going to protrude the tongue to the right side. And that is how, if there is a lesion of the hypoglossal nerve, can you tell me what I want you to understand? If there's a lesion of the hypoglossal nerve, where is the tongue deviated? Bolo bachcho, come on. If there's a lesion of hypoglossal nerve, the tongue is deviated to the same side of lesion. Same side. See, suppose if the right hypoglossal nerve is damaged, the right genioglossus is paralyzed. Okay, right genioglossus is gone. The left genioglossus becomes powerful, and the left genioglossus is going to deviate the tongue to the right side. So in lesions of hypoglossal nerve, the tongue is deviated to the same side of lesion. Am I clear? I hope this should be clear. Students, following now? Okay, great. Very good. Very good. Very good. I can see one more muscle here. If you can tell me what is this muscle? Come on, what is this muscle? And why am I asking you this? There's some very important peculiarity of this muscle. Yes, drug of choice. Bolo bacha, come on. Abir Mani, you're all there, no? One moment, child. Huh? Okay, just one moment. You can all see me, no? Yes. What is this muscle which begins from the genial tubercle and which goes to the hyoid bone? And why should I be asking this to you? Ah, very good, very good. So sorry, I couldn't see the chat. I'm so sorry. Ah, chalo, very nice to all of you. What is this pointed muscle? Come on, can you identify this? Yes, Jasmine. Yes, Shubhangi. Yes, KK. What is this muscle? Begins from the genial tubercle, goes to the hyoid bone. Yes, you identified it rightly. That's the geniohyoid. And why am I asking you this? Geniohyoid. Geniohyoid is supplied by what? Geniohyoid and thyrohyoid, for that matter, are supplied by C1. C1. Just remember the fibers of C1. The fibers of C1, they supply the geniohyoid and the thyrohyoid. Yeah. Geniohyoid, and there's a muscle thyrohyoid, which is a strap muscle. Normally, bacho, the strap muscles, the strap muscles, huh? Thyrohyoid, sternohyoid, sternothyroid, thyrohyoid, and omohyoid. These are the strap muscles, correct? Sternohyoid, sternothyroid, thyrohyoid, and omohyoid. These are the strap muscles. The strap muscles are supplied by ansa cervicalis, except one strap muscle which is not supplied by ansa is thyrohyoid. Thyrohyoid. So who's going to supply the thyrohyoid? C1. C1. Fibers of C1. Which other muscle is supplied by C1? It's geniohyoid. Geniohyoid. So just remember this. I'm not able to see your chat, I think. Huh? Which other muscles are supplied by okay, clear to all of you? Okay, fine. Yeah, in the chat I'm not able to see. So if I have to go back and come, I'm able to see. Okay, fine. Chalo, very good, bacha. So we come back to this MCQ. Answer this. The patient has undergone submandibular gland excision and the Wharton's duct was ligated. Which of the following nerve is most likely to be damaged? Yes, so the answer is lingual nerve. Lingual nerve, right? Now, this inferior alveolar nerve enters the mandibular foramen. It supplies the lower jaw and the lower teeth, and it gets out as the mental nerve. It emerges out as the mental nerve. It supplies the skin over the chin. It doesn't supply the mentalis. No, mentalis is supplied by facial nerve. Right? No? Okay, fine. That's okay. Hypoglossal nerve supplies all the muscles of the tongue except palatoglossus. Okay, which is supplied by vagoaccessory complex. So hypoglossal nerve supplies all the muscles of the tongue except palatoglossus, which is supplied by vagoaccessory complex. Perfect. The marginal mandibular branch of facial nerve. The marginal mandibular branch of facial nerve, yes, it supplies the lower lip. Lower lip. Marginal mandibular. It's a branch of facial nerve as it emerges out of the parotid gland, the temporal, the zygomatic, the buccal, the marginal mandibular, and the last one is the cervical gland. Cervical gland. Perfect. I hope this is clear to all of you. A very important MCQ. I've told you many things. I hope you are able to revise this. Very good. Great. Very nice. Very nice. Yeah. Be interactive, so it will be easy to teach and you to understand. Answer this, bachcho. A patient was admitted with a skull-based trauma and difficulty in swallowing. The doctor was touching the mark structure. So which of the following cranial nerve is being tested? Any guesses? What is the answer for this? It's the glossopharyngeal nerve. Glossopharyngeal nerve. And if you tickle the posterior wall of the pharynx or the soft palate, what happens is That's a gag reflex. Gag reflex. So who's the afferent for the gag reflex? The glossopharyngeal nerve. And who's the efferent for the gag reflex? The vagus nerve, right? The vagus nerve. Afferent is glossopharyngeal and efferent is going to be the vagus nerve. Perfect. That's easy. That's the answer is 9. Gag reflex. Very good, Bacho, very good. In this seat, INICT yesterday on Sunday, INICT, there was one MCQ, the structure passing between the superior and the middle constrictor muscle of the pharynx. Come on, I hope if you must have given INICT, I'm definitely sure you must have answered this MCQ. The structure which passes between the superior and the middle constrictor muscle of the pharynx, that's the glossopharyngeal nerve and stylopharyngeus muscle, the glossopharyngeal nerve and the stylopharyngeus muscle. Correct? Okay, fine. So, Bacho, what I'll do, I'll just tell you in short the course of the 7th nerve. 7th nerve ka ek chota sa course I'll tell you. This will be easy, to answer the MCQs. Yes. The facial nerve, can you tell me which foramen of the skull does it enter? The facial nerve enters the foramen along with the vestibulocochlear nerve and the labyrinthine artery. Can anyone tell me which is that foramen into which the facial nerve is going to enter? That's the internal acoustic meatus, right? So the facial nerve enters the internal acoustic meatus, comes into the internal ear. It comes into the internal ear. The facial nerve enters into the internal acoustic meatus, comes into the internal ear. From the internal ear, now it undergoes a bend, right? It undergoes a bend. And what is this known as? The genu. It undergoes a bend, that's known as the genu. It goes above the promontory, it goes behind the promontory and now gets out through the stylomastoid foramen. It gets out through the stylomastoid foramen. So the facial nerve enters into the internal ear, comes in the middle ear, it goes above the promontory, undergoes a bend, goes behind the promontory and then gets out through the stylomastoid foramen. Now, in the ear, the facial nerve gives 3 branches. Can anyone tell me what are these 3 branches of the facial nerve? 1, 2, and 3. Number 1. Chalo, bacho, if you can answer this, all the MCQs will be clear to you. The facial nerve, it emerges out through the stylomastoid foramen and then enters into a gland here. What's that? The parotid gland, and then gives this 5 branches, right? It gives this 5 branches. So what is that number 1? What is that number 1? It's the greater petrosal nerve. The greater petrosal nerve. Okay. Number 2 is the nerve to stapedius. And number 3 is the chorda tympani. Number 3 is the chorda tympani. Excellent. Very good. Very good. So now, bacho, you tell me if the facial nerve is damaged here. Come on, let us just go through like this. If the facial nerve is damaged at the stylomastoid foramen, if the facial nerve is damaged just after its exit from the stylomastoid foramen, the patient will complain of Bell's palsy. Bell's palsy, that's a lower motor neuron paralysis, right? Bell's palsy. If there's a lesion about this, so if there's a lesion here, so there'll be a Bell's palsy along with the chorda tympani nerve is involved. So the person will complain of loss of taste sensations from the anterior 2/3 of the tongue. Along with, what else is the chorda tympani nerve supply? The submandibular and sublingual glands. So there's going to be a loss of secretions from the submandibular and the sublingual glands. If the lesion is at site B, there'll be a Bell's palsy along with the chorda tympani involvement. So the person will have a loss of secretions from the submandibular and the sublingual gland. Plus, the person will also complain of loss of taste sensations from the anterior 2/3 of the tongue. Perfect and perfect. Okay, now, bacho, if there's a lesion here, just above it, above the nerve to stapedius. So in addition to all this, the nerve to stapedius is involved. The person will complain of hyperacusis. Hyperacusis. Yes. And if there's a lesion here, just after the genu, there's a lesion here, all the nerves are involved. The greater petrosal is gone. Nerve to stapedius is gone, the chorda tympani is gone. In addition, the person will have Bell's palsy. So what will the person complain of? Number 1 is Bell's palsy. Number 2 is hyperacusis. Number 3 is loss of taste sensations from the anterior 2/3 of the tongue and loss of secretions from all the glands except, come on, answer this. Loss of secretions from all the glands except one gland which is not supplied by the facial nerve. yes, the secretions are going to be intact. Now this is a test and discussion, bacha. Okay, so what are maximum I can cover? I'm trying to tell me loss of secretions from all the gland except bacha, except Dr. Coel, except Dr. Coel Maiti, except parotid. You got this. Yes, very good. Except parotid. That means there'll be a loss of secretions from all the glands except parotid, because this parotid gland is supplied by which nerve? Come on. That's a very important MCQ. The parotid gland is supplied by glossopharyngeal nerve. Excellent. The parotid gland is supplied by glossopharyngeal nerve. Very good, bacho. Excellent. Very nice. You're answering very well. Can you tell me what is the name of the component if a cranial nerve has to supply the glands? What component should the cranial nerve have in its nucleus? Come on, bacho. The question is open to you. If a cranial nerve has to supply the glands, what is that component which the cranial nerve will have in its nucleus? The name of the, I hope you're understanding, right? The name of the component is, yes, it's the general visceral efferent component, or it is also known as secretomotor component. Secretomotor component. Hello, क्या हुआ? General visceral. Okay, that's okay, bacha. That's okay. Don't worry. You make mistakes here. That's okay. That's not to worry. Okay, so that's the general visceral efferent or the secretomotor component. So this component will be present in the nerves which are going to supply the glands. In other words, this component will be present in which nerves? 7, 9 and 10th nerve. Plus, we also include the third nerve in this. The third nerve does not supply any glands, but this component represents the parasympathetic nervous system, and the third nerve supplies two muscles which are parasympathetic, the sphincter pupillae and ciliaris, and that is why we take the third nerve in this component, right? General visceral efferent. Now, what my question is, what is the name of the nucleus of third nerve which is going to supply the sphincter pupillae and ciliaris muscle? Come on. Can you answer this? That's a very important MCQ that we're discussing. What is the name of the nucleus of the third nerve which is going to supply the sphincter pupillae and the ciliaris muscle, which belongs to the general visceral efferent component? Come on, bacho. Come on, you can guess. No, you can guess. No problem. You guess. Even if you make mistakes here, that's okay. क्या बच्चों क्या हाँ वेरी गुड अबीर मनी एक्सीलेंट दैट्स द एडिंगर-वेस्टफाल nucleus. Edinger-Westphal nucleus. So the name of the nucleus of the third nerve which is going to supply the sphincter pupillae and the ciliaris muscle, that's Edinger-Westphal nucleus, right? What is the name of the nucleus of seventh nerve which is going to supply all the glands in the head and neck except parotid? The name of the nucleus of facial nerve is superior salivary nucleus and the lacrimatory nucleus. Very good, very nice. Very good, you're answering very well. That's the superior salivary nucleus and the lacrimatory nucleus, right? What's the name of the nucleus of the ninth nerve which is going to supply the parotid? Any guesses? What is the name of the nucleus of the ninth nerve which is going to supply the parotid? Come on, bacho, come on, you can answer this. Yes, Jasmine, bacha, very good, very good. Very good. What is the name of the nucleus of the ninth nerve? Ninth nerve, that's the inferior salivary nucleus. Are you able to understand this? You get, yes, you get MCQs on the nucleus also. So, which is the name of the nucleus of third nerve? Edinger-Westphal. Seventh nerve, superior salivary nucleus, lacrimatory nucleus. Ninth nerve, it's the inferior salivary nucleus. And the 10th nerve is the dorsal nucleus of vagus. Dorsal nucleus of vagus. So the name of the nucleus of 10th nerve is dorsal nucleus of vagus. And bacho, my dear children, do you know where is this dorsal nucleus of vagus? It lies in the floor of the fourth ventricle. It forms an elevation in the floor of fourth ventricle. That's the vagal triangle. Vagal triangle. I hope you are able to correlate all this. समझ में आ रहा है ना बच्चों? See, I'm trying to cover what a maximum I can. And this is a test and discussion, so I'm sure you must be knowing most of it. It's just a orientation to everything. Okay, fine. Perfect. You're answering very well. Excellent, very good. Okay, fine. Chalo. And as we proceed, we'll discuss many things. That's nice. That's nice. That's nice. Come on, answer this, bacho. Answer this. The structure marked A in the image given below gives rise to which of the following structures? Can anyone tell me? Thank you, thank you, thank you. Okay, how do I tell you this? One moment. Now this I have to tell you directly, so thoda sa. Okay, let me explain it like this. See, during development, this stomach, if I draw this as the stomach, this stomach is attached to the anterior abdominal wall and the stomach is attached to the posterior abdominal wall. This is the anterior abdominal wall, that's the posterior abdominal wall. Can you tell me what is that fold of peritoneum by means of which the stomach, from the stomach to the anterior abdominal wall, this is what we call as the ventral mesogastrium. Ventral mesogastrium. From the stomach to the anterior abdominal wall, that fold of peritoneum in fetal life is known as ventral mesogastrium. Perfect. From the stomach to the posterior abdominal wall, this is what we call as the dorsal mesogastrium. Right? The dorsal mesogastrium and ventral mesogastrium. That's perfect. Now, this is the stomach, bacha. Now you tell me there's someone who develops in the ventral mesogastrium. Who's this? Who's this who develops in the ventral mesogastrium? Yes, that's the liver. The liver is formed in the ventral mesogastrium. Actually, the liver is derived from the GIT. The liver is a derivative from the GIT, and this liver goes towards the ventral mesogastrium. The liver grows in the ventral mesogastrium and the septum transversum. The moment the liver develops in the ventral mesogastrium, it is going to divide this ventral mesogastrium into two parts. Remember it like this, it's very easy. The moment the liver grows here, it divides the ventral mesogastrium into number 1. What is this going to be? From the liver to the anterior abdominal wall, this becomes the falciform ligament. Okay, so falciform ligament is in fact, because the liver grows in the ventral mesogastrium, so jitne bhi ligaments hai, all the ligaments of liver would be derived from ventral mesogastrium. You just remember it like this, right? So the superior layer of coronary ligament, the inferior layer of coronary ligament, the right and the left triangular ligaments, all the ligaments of liver would be derived from ventral mesogastrium. So this becomes a falciform ligament, and this becomes what? From the liver to the stomach, this becomes the lesser omentum. Lesser omentum. Perfect. Right. And there's a collection of lymphoid tissue which comes in the dorsal mesogastrium, which is going to form the spleen here. So the spleen develops in the dorsal mesogastrium, and because the spleen develops in the dorsal mesogastrium gets divided into two parts. One, from the stomach to the spleen, this is what we call as the gastrosplenic ligament. Gastrosplenic. And from the spleen, behind is going to be the kidney on the posterior abdominal wall. So this is what is known as the lienorenal ligament. Okay, so bacho, just remember it like this. So gastrosplenic ligament and lienorenal ligaments are derived from where? They're derived from dorsal mesogastrium. Whereas the falciform ligament, the lesser omentum, is derived from ventral mesogastrium. Right? And the stomach then turns. Embryo mein, the stomach then turns like this, and because the stomach turns, let me just tell you this. Look, because the stomach now turns like this towards the left side. So this is the ventral mesogastrium. And you know what? The dorsal mesogastrium goes like this, and that's the posterior abdominal wall. The spleen, which was behind, now goes to the left side. Okay, this is the left side. I'm drawing this as the left side. The spleen goes to the left side. This becomes a gastrosplenic ligament. That becomes a lienorenal ligament. And bacho, if you can tell me, what is this that I've drawn for you? What is this area now? What is this area? I hope you are able to follow this. In a small time, in a very less time, I'm trying to tell you many things. What is that dotted area that I've drawn for you? Can anyone tell me this? The stomach is first like this. Now the stomach is first like this. Then the stomach turns to the left side. Because the stomach turns to the left side, the dorsal mesogastrium also turns like this. And because the dorsal mesogastrium turns like this, the spleen goes to the left side. So that the gastrosplenic and the lienorenal ligament goes on that side. So what is this dotted structure there? Great omentum nahi hai bachcha wo. Nahi, it's not great omentum. It's a cavity, my dear child. It's a cavity which is formed behind the stomach, and this cavity is formed because of the rotation of the stomach, and this is what we call as, yes my dear children, this is what we call as the lesser sac. Lesser sac. That's the lesser sac. You understand how the lesser sac is formed, right? So lesser sac ka one boundary would be formed by the gastrosplenic and the lienorenal ligament. Which boundary? The left boundary would be formed by the gastrosplenic and lienorenal ligament. Excellent, very good. You've all answered this. Very nice, lesser sac. And so left boundary of the lesser sac would be formed by gastrosplenic and lienorenal ligament, right? Now if you go to the right side of the lesser sac, there's a foramen here. Can anyone tell me what is that foramen known as? And I can go from this outside into the greater sac. What is that foramen? That's the epiploid foramen. Epiploid foramen. See, what I want you to understand is lesser sac ka left boundary is formed by gastrosplenic and lienorenal ligament, whereas the right boundary is formed by the epiploid foramen. Very good. Excellent. Excellent. Very good. I hope you're getting this. Now, there's one more MCQ which can be asked. Look, what is the content of falciform ligament? Huh? Now something different. What is the content of falciform ligament? Can anyone answer this? Content of falciform ligament. Another very important MCQ bacha. What is the content of falciform ligament? It's the ligamentum teres and para umbilical veins. Contents of falciform ligament is ligamentum teres and the paraumbilical vein. Okay, what are the contents of lienorenal ligament? Excellent. Abirmani, very good. What are the contents of lienorenal? Can anyone tell me? Contents of lienorenal ligament is the tail of pancreas and splenic artery. Tail of pancreas and splenic artery. And just remember this, this is extremely important. So what are the contents of lienorenal ligament? The splenic artery and the tail of the pancreas, and the branches of splenic artery. The branches of splenic artery, they line the gastrosplenic ligament. So my dear children, which branches would that be? Which are the branches of splenic artery? The short gastric, and the left gastroepiploid. The short gastric and the left gastroepiploic artery, they line the gastrosplenic ligament. Just remember all these things. Just remember all these things. They're very important MCQ. I hope I'm trying to cover. Very good. Yes, Dr. 𝐒𝐿, very good. So the short gastric and the left gastroepiploic arteries, these are contents of gastrosplenic ligament, and the splenic arteries are content of lienorenal. Perfect. Very good. I hope this is clear to all of you. MCQ here. Chalo, answer this MCQ bacho. The structure marked A gives rise to, the answer is falciform ligament. Falciform. So A is ventral mesogastrium. A is ventral mesogastrium, gastrosplenic, lienorenal, and the gastrophrenic. These are all derivatives of dorsal mesogastrium. They are derived from dorsal mesogastrium. Perfect. Very good, KK. Very good. Very good. Let us go to the next MCQ, children. Okay, here we go. Here we go. A patient underwent surgery for varicose veins. He now complains of sensory loss over the medial aspect of the leg and the foot. Medial aspect of the leg and the foot. Which of the following nerve is most likely to be injured? Any guesses? Any guesses? Saphenous nerve. Very good. KK, excellent. So this is saphenous nerve. You know what is this saphenous nerve? Saphenous nerve is a branch of what? let me just tell you something about the saphenous nerve. This saphenous nerve is the largest cutaneous branch of femoral nerve. Just remember this. Largest cutaneous branch of femoral nerve. Largest cutaneous branch of femoral. This saphenous nerve accompanies a vein. It accompanies the great saphenous vein. The saphenous nerve is accompanying the great saphenous vein. The saphenous nerve supplies the skin on the medial aspect of the leg. Yo, that's a slide. So the saphenous nerve supplies the skin on the medial aspect of the leg and the foot up to the great toe. Yes, very good, very good. It's the largest cutaneous branch of femoral. That's another MCQ for you. The largest cutaneous branch of femoral nerve is saphenous nerve, accompanies the great saphenous vein, supplies the skin on the medial aspect of the leg and the foot up to the ball of great toe. Up to the ball of great toe. I'll just draw a beautiful slide for you. Another very, very, very important slide which is asked in most of the exams. Have a look at this. Very important question, visuals, anything can be asked on this. So be very clear about this, no confusion here. So that's a sole. This is the sole of the foot. This is not the dorsal aspect, that's the sole of the foot, plantar aspect of the foot. Now children, tell me who's going to supply the skin on the medial aspect of the foot, leg and the foot up to the great toe. Up to the ball of great toe. That's the saphenous nerve. This is the saphenous nerve. Supplies the skin on the medial aspect of the leg and the foot up to the ball of great toe. Now, my dear children, tell me who's going to supply the medial aspect of the great toe. Yes, answer this, bacha. Answer this. Who's going to supply the medial aspect of the great toe? And the same nerve is going to supply all the web spaces. All the web spaces. These are the web spaces except the first. Not the first. Who's this? In yellow. This you should know. This is the superficial peroneal nerve. That's the superficial peroneal nerve. You know superficial peroneal nerve, no? It is the nerve of the lateral compartment of the leg. This superficial peroneal nerve supplies the peroneus longus, peroneus brevis, and this superficial peroneal nerve supplies the skin on the dorsal aspect of the foot. The superficial peroneal nerve also supplies the skin on the medial aspect of the great toe. It supplies all the web spaces except the first web space. Who supplies this? That's the deep peroneal nerve. Deep peroneal nerve. This is supplied by the deep peroneal nerve, right? Where we put slippers, no? That web space, the first web space, that is supplied by deep peroneal nerve. And my dear children, who is going to supply the skin on the lateral aspect of the foot? Any guesses? That's the sural nerve. And sural is a branch of tibial nerve. Yes, sir, yaad rakhna, bacha. This all is very, very important. Just remember this. The lateral aspect of the foot is supplied by sural nerve. Now, the heel. The heel is supplied by which nerve? Tibial nerve. The heel is supplied by the tibial nerve. Now, coming to the main part of it, 3.5 fingers on the medial aspect. 3.5 fingers, skin on the medial aspect of 3.5 fingers is supplied by the medial plantar nerve. And this 1.5 fingers is supplied by lateral plantar nerve. Medial and lateral plantar nerves are branches of tibial nerve. Both are branches of tibial nerve. This is clear? Any doubts? If it's not clear, bacha, you just let me know. Tibial nerve is going to supply the heel, the plantar aspect of the sole, that's a heel. 3.5 fingers on the medial aspect is supplied by medial plantar nerve, and 1.5 fingers on the lateral side is supplied by the lateral plantar nerve. I hope this is clear. Now this medial plantar nerve, you tell me, bacha, who's going to supply this skin on the lateral aspect of 3.5 fingers on the hand? 3.5 fingers here, who's going to supply that? Any guesses? In the hand. In the hand. That's a medial nerve. So medial nerve of the upper limb corresponds to which nerve of the lower limb? That's a medial plantar nerve. And who's going to supply this 1.5 fingers? That's the ulnar nerve, which corresponds to the lateral plantar nerve. So just try to correlate the hand and the foot. Clear? Is this clear, my dear children? Are you able to understand this? These are all very, very important things that I'm telling you. Huh? I'm not remaining confined to the MCQ. Whatever in my way, I'll tell you. Perfect. Let us proceed. So what's the answer for this? Wait. So that's clear. The answer is saphenous nerve. Superficial peroneal nerve is a nerve which compartment? That's a nerve the lateral compartment of the leg. Lateral compartment. The deep peroneal nerve is a nerve anterior compartment. Anterior compartment does what? Dorsiflexion. Dorsiflexion. Lateral compartment does eversion of the foot. If the dorsiflexion is lost, what will happen? Tell me. If the deep peroneal nerve is damaged, what will happen? It leads to foot drop. Foot drop. Yeah. So dorsiflexion is lost, the foot goes down. That's foot drop. And what is the gait? If there's a foot drop, there's a high stepping gait or stamping gait. Clear? Drug of choice clear? Yes. Abir Mani, KK, Bacho, Jasmine, very good, very good, very good. All of you answering very well. Anatomy is very strong. Very good. Sure. Let us proceed then. Yes. Can anyone identify this? Identify the type of cartilage. Excellent. If you have confidence on the basic sciences now, you'll have confidence in all the subjects. Remember. Shall answer this, bacha. Identify the cartilage given below. So, what is the characteristic of cartilage? I get cells in the cartilage which are known as chondrocytes, right? Chondrocytes. So, the moment I find chondrocytes, that's a cartilage. Now, what else do I see? I see the ground substance and a ground substance. If the ground substance is amorphous, glass-like, what is that cartilage? It's a hyaline cartilage. Just have a look at this. So what is this cartilage? What do you think this cartilage is? This is a hyaline cartilage. Perichondrium is present in a hyaline cartilage. Articular hyaline cartilage, perichondrium is absent. If hyaline cartilage, perichondrium is present. If it's an articular hyaline cartilage, the perichondrium is going to be absent. So how do I know this is a hyaline cartilage? Because I see chondrocytes. And the very characteristic is the chondrocytes are found in a group. Can you see this, bacha? Can you see this? This group of chondrocytes are known as cell nest. Cell nest. So this cell nest is a characteristic of hyaline cartilage. The chondrocytes are found in groups, and as we go towards the center, the chondrocytes becomes larger. Towards the periphery, the chondrocytes are small. This is hyaline cartilage. Where do we get this hyaline cartilage? This is trachea. Trachea. Yes. Anywhere else do we get hyaline cartilage? Cricoid, thyroid. We get hyaline cartilage. Okay, perichondrium is present. Chondrocytes are found in groups. The ground substance is amorphous, glass-like, hyalos. So that's hyaline cartilage. I've told you the sites: trachea, cricoid, and thyroid. Perfect, perfect. Now, what is this cartilage? Look, bacha, what is this cartilage? Perichondrium is present. Huh? Perichondrium is there. Yes. I find the largest size of chondrocytes. Sabse bade chondrocytes. The largest size of chondrocytes. And this is going to be the elastic cartilage. Elastic. And how do I know this is elastic cartilage? Because yes, I do get elastic fibers here. Elastic fibers. So, elastic fibers in the background. Largest size of chondrocytes. And the perichondrium is present. So this is elastic cartilage. Example is pinna. Example is epiglottis. Epiglottis. Pinna, epiglottis. Okay, so this is elastic cartilage. And the third type of cartilage, bacha. The third type of cartilage wherein the perichondrium is absent. The perichondrium is absent. I find chondrocytes. Yes. And between the chondrocytes, we get thick bundles bundles of collagen fibers. So this is what is the collagen fibers. Collagen fiber. So what is this cartilage? This is a white fibro cartilage. I've got one more slide for you, but just look. You can see these chondrocytes and you can see bundles of collagen fibers here. So this is a white fibro cartilage. Right? Examples of white fibro cartilages: intervertebral disc, meniscus, articular disc. Intervertebral disc, meniscus, articular disc. So these are all examples of white fibro cartilage. Am I clear, bacha? You should be able to identify this histology slides also. So the answer for this is going to be white fibro. Okay. What is the difference between a articular hyaline cartilage and non-articular? This perichondrium is present. In this perichondrium is absent. Perichondrium is absent. And articular hyaline cartilage. Perfect, bacho. Yes. Are you all there? Come on. Hello, hello. Answer, answer. Fine. So that's how you identify this. Sites of cartilage, the sites you should know and the characteristic you should know. Perfect. Perfect. Very good, children. Go to the next slide. Here we go. So, a patient presents with unilateral throbbing headache, photophobia, and excessive lacrimation. He also complains of hemifacial pain on clenching of teeth. What is this? Clenching of teeth. When a person clenches his teeth, he gets a facial pain. So, what is this involvement of? Involvement of what? Are you all there? I'm not able to see this now. Chat sometimes. Okay. Okay, I couldn't see your. Okay, very good. You're all answering very well. I couldn't see your chats. Excellent, very nice. So what is this? A clenching of teeth. A person gets facial pain. Involvement of TM joint. Involvement of temporomandibular joint. It is. On examination, pupillary reaction, light reflex, accommodation reflex is normal. So the third nerve is normal. Here. So which of the mark structures is involved in the above scenario? Can you identify this, bacha? Can you identify this number 1? What is this number 1? That's number 1 is optic nerve. Right now, this is a bunch of nerve which is going towards the superior orbital fissure. What is this 3? This 3 is the trigeminal nerve. Number 3 is the trigeminal. So that's involvement of trigeminal nerve. The trigeminal nerve supplies the temporomandibular joint. Answer is C. Answer is C. I hope this is clear to all of you. But I'll be able to see the chat. Okay. The answer is C for this. Trigeminal nerve. It supplies a TM joint. So answer is trigeminal nerve for this. The trigeminal nerve divides into ophthalmic, maxillary, mandibular. The ophthalmic division enters the orbit through the superior orbital fissure. The maxillary division enters leaves the skull through which foramen? Can anyone tell me? The maxillary division leaves the skull through which foramen? That's the foramen rotentum. And the mandibular division leaves the skull through foramen ovale. Yes, very good. See, if I draw a structure like this, can you tell me what is this that I am drawing? Look, if I draw a structure like this and I just ask you, what is this that I've drawn? What is this that I've drawn? just a visual for you. Bol sakte ho? Yes, bachcho, come on, answer this. What? Yeah, med student. That's excellent. That's a cavernous sinus. Bacha, you should be able to identify this line diagrams also. That's the cavernous sinus. That's very nice. That's a cavernous sinus. So that's the lateral wall of cavernous sinus, in which this is the third nerve, that's the fourth nerve, that's the ophthalmic division, and that's the maxillary division of trigeminal nerve, which is related in the lateral wall of cavernous sinus. In the floor is the sixth nerve, and this is the internal carotid artery. On the medial side, yes, we get this pituitary gland and this sphenoidal air sinus. Sphenoidal air sinus. Very good, very good. Sixth nerve floor mein bacha, huh? Abhir Mani, sixth nerve is in the floor. Very nice, huh? Excellent. Very good. I'm very happy. You're answering very well. Chalo bachcho, can you identify this? Identify this, identify this, identify the given structure. Okay. Any guesses? Any guesses? Yes, any guesses in this? Identify the given structure. So what is the slide of pancreas? Huh? That's pancreas. Very good. That's the islets of pancreas. So this is the islets of pancreas, and this is the exocrine part of the pancreas. That's the endocrine part of the pancreas. The exocrine. Suppose if islets is not seen, bacha, if islet is not seen, only this part is seen. Only this part is seen. What do you identify this as then? Suppose if the islets of Langerhans is not seen, the moment you see the islets of Langerhans, we identify this as pancreas. Yes, that's correct. But what I'm asking you is, if the islets of Langerhans is not seen, you see only this, what do you identify this as? In other words, I'm asking you, what does the exocrine part of the pancreas resemble? This you should know, my dear children. That's a serous salivary. It resembles a serous salivary gland. So that's parotid. Example is parotid. Very good. So normally I see acinus. I see serous acinus. I think this is a serous salivary gland. This is a parotid gland. But as I'm searching, accidentally I find the islets of Langerhans. And yes, the moment I find islets of Langerhans, I know this is pancreas, because islets represents the endocrine part of the pancreas. The exocrine part of the pancreas is a serous salivary gland. Serous salivary, right? So what is the characteristic of lymph node? Can anyone tell me the characteristic of lymph node? The characteristic would be, you get a capsule here, and just below the capsule you get a space here, and below the space you get lymphoid follicles here. Lymphoid follicle. So this space is known as the subcapsular sinus. That's an MCQ which was asked. Subcapsular sinus. So, bacho, if the MCQ comes, the subcapsular sinus is a characteristic of, your answer is lymph node. Lymph node. So, subcapsular sinus is a characteristic of lymph node. You've got a capsule, you've got the subcapsular sinus, then you've got lymphoid follicles. All the afferent lymphatics will come and open in this subcapsular sinus, and the lymph is filtered in the sinus. Lymph is filtered, and then the filtered lymph gets out through the efferents. What is the characteristic of spleen? Spleen, we get a red pulp and a white pulp. Red pulp and white pulp is a characteristic of spleen. And in the white pulp, we get an eccentric arteriole. Eccentric arteriole, and arteriole which is pushed to the periphery. Okay. What is the characteristic of thymus? Can anyone tell me? Thymus, we get small thymus. So lymphoid follicles are absent in the thymus. Lymphoid follicles are absent in the thymus. We've got this thymic lobules like this. We've got a capsule here, and the capsule will divide the thymus into small lobules, which are known as thymic lobules. Each thymic lobule has got an outer cortex and an inner medulla. And this medulla shows this rounded. What are these? Hassel's corpus. So remember thymus, bacha. Capsule is present. Lymphoid follicles are absent in thymus. Just remember that. We have got 4 lymphoid tissues, right? Lymph node, spleen, tonsil, and thymus. In all this 4 lymphoid tissue, we get lymphoid follicles. I mean, in this lymphoid tissue, we get lymphoid follicles, except in thymus, lymphoid follicles are absent. Remember this. Lymphoid follicles are absent in thymus. Thymus में the capsule will send septa, which divides the thymus into lobules. Each lobule has got an outer cortex and inner medulla. And what does the medulla contain? Hascels, corpuscles. That's it. And the fourth lymphoid tissue is spleen, tonsil. In tonsil, what do we get? We get such crypts like this. Crypts. What are these known as? Tonsillar crypts. And what is the epithelium of tonsil? It's stratified squamous, non-keratinized epithelium. Stratified squamous, non-keratinized epithelium. That's the epithelium of tonsil. Clear, bachcho? Stratified squamous, non-keratinized. I hope this is clear. So that's how you differentiate between different lymphoid tissues. Yeah. Okay, fine, perfect. We proceed. Chalo bachao, answer this MCQ. A 23-year-old male presented to the OPD with complaint of not being able to dorsiflex the foot. Now you'll be able to answer this. Which of the following points the nerve would be damaged to have this above finding? Come on, answer this. Easy MCQ. Easy MCQ. Answer is C. Answer is C. Right? That's the common peroneal nerve. Common peroneal nerve. Hey, hello. Okay, I got it. C is common peroneal nerve. See, just one moment. In a quick nutshell. Chalo, just tell me, leg. In a quick nutshell, leg has got three compartments. One is posterior compartment, one is anterior compartment, and one is lateral compartment. Which are the muscles in the posterior compartment? The gastrocnemius soleus and plantaris. The deep muscles are the tibialis posterior, the flexor hallucis longus, the flexor digitorum longus, and popliteus. What is the action of popliteus? Unlocking of knee joint. Popliteus does unlocking of knee joint. Rest all the muscles do what? Plantar flexion and inversion. Plantar flexion and inversion. Clear now? Gastrocnemius soleus and plantaris. They form this superficial group of muscles. The deep muscles in the posterior compartment of the leg are, one is popliteus. Action of popliteus is unlocking of the knee joint. The other muscles are tibialis posterior, the flexor hallucis longus, and the flexor digitorum longus. Action of this deep muscles is plantar flexion and inversion. Which is the nerve this compartment? The nerve this compartment is tibial nerve. Right? Which are the muscles in the anterior compartment? Anterior compartment muscles, just I'm enumerating it. Tibialis anterior, extensor hallucis longus, extensor digitorum longus, and peroneus tertius. Right? What is the action of all these muscles? The action of all these muscles is dorsiflexion, and tibialis anterior also does inversion. What is the nerve supplying here? That's a deep peroneal nerve. Lateral compartment, the muscles are peroneus longus and peroneus brevis. Action is eversion of the foot. The nerve is superficial peroneal nerve. So just in a nutshell, I've told you the leg, the various muscles of the leg, the nerves in the leg. The nerve of the posterior compartment is tibial nerve. The action of the muscles of posterior compartment is plantar flexion. So if you get a MCQ stating a person is not able to stand on the tip of the toes, come on, answer this. A person is not able to stand on the tip of the toes, which is the nerve affected. Standing on the tip of the toes. In schools, there's a punishment. Stand on the tip of your toes. When you stand on the tip of the toes, which muscles contract? The posterior compartment muscles, the calf muscles. And we stand for half an hour, start getting cramps there. So person is not able to stand on the tip of the toes. The nerve involved is tibial nerve. The nerve injured is tibial nerve. A person is not able to dorsiflex the foot. There's a foot drop. Deep peroneal nerve. And the person is not able to evert the foot. That means lateral compartment is paralyzed. The nerve is the superficial peroneal nerve. And this superficial peroneal nerve is going to wind around the neck of the fibula. It then divides into, the common peroneal nerve winds around the neck of the fibula, then divides into a superficial peroneal and a deep peroneal nerve. Perfect. And you know the nerve supply of the leg also, the foot also. Okay, perfect. Very good. So this is clear, no? Medial cutaneous nerve is a branch of femoral nerve. This is a branch of femoral nerve. Can anyone tell me what is the root value of femoral nerve? Femoral nerve ka root value? Anyone? Anyone, bacha? Tell me what is the root value of femoral nerve? Yes. Yes, drug of choice. Very good. Jasmine. Very good. Prem. Abir Mani. Very good. KK. Yes, you are all answering very well. Very well. Will definitely come with flying colors, bacha. Very good. So basics are very strong. Med student. Sorry, med student. Dr. Coel. Yes, you have been answering very well, all of you. What is the root value of femoral nerve, bacha? I want you to know the root value of femoral nerve. It's P4. And there's another nerve which is known as obturator nerve. Jiska root value is L2, P4. Okay, L2, L3, L4. Very good. What is the difference? Excellent. Very good. What is the difference, bacha? दोनों का root value is L2, L3, L4. So what is the difference? Yes, yes, yes. Very good. So femoral nerve is formed by the dorsal divisions of ventral rami. Ventral ramus of L2, L3, L4, and this is formed by the ventral divisions of ventral rami. Ventral division of ventral rami of L2, 3, 4 is obturator nerve. The dorsal divisions of ventral rami of L2, L3, L4 is femoral. Dorsal is posterior division, ventral is anterior. Very good. Excellent, 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 excellent. Okay, anything else? That's fine. Here, can you answer this, bacho? A very easy MCQ for you. The marked structure in the below image is a defect in which of the following? So this is the marked structure. This is the marked structure. Hello. Answer this. What is this marked structure? That's a deep inguinal ring. And a deep inguinal ring is a defect in. What is the answer? The deep inguinal ring is a defect in fascia transversalis. Yes, the deep inguinal ring is a defect in fascia transversalis. The superficial inguinal ring is a defect in the external oblique aponeurosis. The superficial inguinal ring is a defect in external oblique aponeurosis. The deep inguinal ring is a defect in fascia transversalis. What is conjoint tendon? It's the internal oblique plus transverse abdomen. Yes, conjoint tendon is internal oblique plus transverse abdominis. Okay, fine. Now, bacha, I'll just draw something for you. Just have a look and quickly tell me. That's the rectus abdominis. This is the pubic symphysis. That's the inguinal ligament. This is the superficial inguinal ring. That's a deep inguinal ring. And my dear children, you tell me who's this? Yes, chalo bacha, you tell me what is this red structure? What is this red structure? What is this red structure that I've drawn? Which is medial to the deep inguinal ring, and that's the inferior epigastric artery. You know this inferior epigastric artery, you know. So this is the inferior epigastric artery. That's the rectus abdominis muscle. That's the inguinal ligament. This becomes the Hasselbalch's triangle. Any hernia which is coming from the deep ring, entering the inguinal canal and coming through the superficial ring is an indirect inguinal hernia. And any hernia, if it gets out through the Hasselbalch's triangle, is a direct inguinal hernia. This you know. Now, I'm interested in something else. But Joe, can you tell me who's this? This is something which is dividing Hasselbalch's triangle into further two parts. This structure is going to divide the Hasselbalch's triangle into further two parts. A hernia, if it comes out from here, this is direct, right? A hernia coming out from here is also direct. But if a hernia comes out from here, it is known as a medial direct. Medial direct. And if a hernia coming from number 2 is a lateral direct hernia. What is that green structure? What is that green structure which divides the Hasselbalch's triangle into two parts? Yes, bacha, I want this. I want that. Hasselbalch's triangle clear hai bacha? If a hernia gets out through the Hasselbalch's triangle, it's a direct inguinal hernia. There's this green structure which divides the Hasselbalch's triangle into further two parts. If a hernia comes from this side, it's a medial direct. If a hernia comes from that side, it's a lateral direct. So what is that green structure? Follow. You must be knowing this. Just guess, bacha, guess. You can guess. Yes, Abhirmani, guess karo. Vaishali, yes, any guesses? Yes, Jasmine, Dr. Coel. What is that green structure? Nahi? Nahi? Can't guess. The green structure is obliterated umbilical artery, or it is also known as, yes, medial umbilical ligament. I've got the slide. I'll show you this later. The obliterated umbilical artery or the medial umbilical ligament is the one which is going to divide the Hasselbalch's triangle into two parts. The obliterated umbilical artery or the medial umbilical ligament divides the Hasselbalch's triangle into two parts. This you should know, bacha. This is very important. Good that you are learning something good. So this obliterated umbilical artery or the medial umbilical ligament is going to divide the Hasselbalch's triangle into two parts. If a hernia comes medial to this obliterated umbilical artery, it is a medial direct hernia. If it comes from a lateral side, it's a lateral direct hernia. Clear, bacha? So just remember this. Excellent. Very good. Very good. So just see the slide. It's a beautiful slide. If you can quickly identify the muscles, if it comes as a visual, yes, it could come as a visual. That's the external oblique. That's the transverse abdominis. That's the fascia transversalis. That's the extraperitoneal fat, and this is the peritoneum. Perfect, bacha? Yeah, so that's the external oblique aponeurosis, internal oblique, transverse abdominis, fascia transversalis, extraperitoneal fat, and peritoneum. If this comes as an MCQ, you should be knowing this, right? What is this structure? Chalo, if you can answer this, what is this? What are these vessels? What are these vessels? That is the inferior epigastric artery. That's the inferior epigastric artery. And what is this? This is the one which I'm telling you, bacho. This is the one which I'm telling you. This is the obliterated umbilical artery. Here. This is the obliterated umbilical. This elevation, dekh rahe ho? This elevation. That's the obliterated umbilical artery. Perfect. Okay, that's fine. That's fine. I just want you to see one thing which can come as a visual, bacha. This can come as a visual. Can you tell me what is this nerve? Any guesses? What's this nerve? And this is the nerve which is lying between the internal oblique and the transverse abdominis muscles. Come on, guess this nerve. Have you seen this nerve? It's present between the internal oblique and the transverse abdominis muscle. You try to guess it. If you can't, then I'll give you a hint. Chalo bacha, answer this. You guess. You make mistake, that's fine. Genitofemoral nahi hai bacha. Genitofemoral nerve does not come here. Genitofemoral enters the spermatic cord. In fact, genitofemoral nerve will be somewhere inside this. Abhirmani, yes, drug of choice. Genitofemoral nerve will be inside the spermatic cord. Yes, very good. Abhirmani is identified it very correctly. That's the ilion-inguinal nerve. ये जो nerve है ना between the internal oblique and the transverse abdominis is the ilion-inguinal nerve. Now this ilion-inguinal nerve is going to pierce the internal oblique. Okay, then it comes in the inguinal canal. So ilio-inguinal nerve is said to be a direct, incomplete content of the inguinal canal. It pierces the posterior wall of the inguinal canal, comes inside, and then gets out through the superficial inguinal ring. Right? That's the ilio-inguinal nerve. Just remember this, bacha. This can come as a visual for you. Excellent. Very good. All of you clear now? Okay. Excellent. Chalo. Answer this MCQ. Here we go. Which of the following muscle is attached to the articulate disc of TM joint? Answer this. This you should know. This you should know. Which of the following muscles is attached to the articular disc of TM joint? Bacha, this can be a MCQ. This can be a visual slide also. I'll show you the visual slide. Well, it's not B. No, it's the lateral pterygoid. Very good. It's the lateral pterygoid. That's the lateral. It's the lateral pterygoid. Look at this. Look at this slide. Look at this is beautiful. I mean, just appreciate the slide. It's beautiful. Suppose if this comes as a visual slide for you, and if this is pointed, this is pointed. What is this that I'm showing you? What is this that I'm pointing? See, bacho, if you make mistakes, you'll always remember this. You'll never make a mistake in the final exam. Yes. What is this that I'm pointing? Any guesses? What is this that I've pointed? Yeah, joint is TM joint, bacha. The joint is TM joint, but I'm pointing something. This is the articular disc. This is the articular disc. Hey, that's a TM joint. That's a articular disc of the TM joint. And can you see this? This articular disc of TM joint is a degenerated part of this. Is the pterygoid. This muscle is the lateral pterygoid, right? And the lateral pterygoid gets degenerated, forms the articular disc. How do you justify this? Look, there was an MCQ. Look, there was an MCQ. In dislocation of the TM joint, right? When there's a dislocation of the TM joint, this lateral pterygoid undergoes spasm. It goes into spasm. And because it goes into spasm, it pulls the articular disc of TM joint forwards. So in dislocation of TM joint, the articular disc is pulled forwards by lateral pterygoid. Just remember, it's pulled forwards by the lateral pterygoid muscle. What is this muscle? This is the medial pterygoid. That's the medial pterygoid. Yeah. What is this muscle? Can anyone identify this muscle? That's the buccinator muscle. This is the buccinator. And what is this structure which is piercing the buccinator? I know for sure this is buccinator. How? Because there's someone who's piercing the buccinator, and that's the parotid duct. Parotid duct. Okay, now the parotid duct pierces the buccinator. Perfect, bacha. Where are the rest of you? Hello, hello. So that's a buccinator, and that's a parotid duct. Perfect, perfect. Very good. Clear to all of you? Tell me. Who's going to supply the lateral pterygoid? That's the anterior lateral pterygoid, masseter, and temporalis. These three are supplied by anterior division of mandibular nerve. Anterior division of mandibular nerve is going to supply the lateral pterygoid, the masseter, and temporalis. Who's going to supply the medial pterygoid? Can anyone answer this? The medial pterygoid is supplied by mandibular nerve, but no, it's not the anterior division. Who's going to supply this? Any guesses? Who's going to supply the medial pterygoid? It's the trunk of the mandibular nerve. That's an MCQ, bacha. That's an MCQ. Trunk of mandibular nerve. The trunk of mandibular nerve is going to supply the medial pterygoid. The trunk of mandibular nerve supplies the medial pterygoid. It also supplies two more muscles. Yes. Which are those two more muscles? It supplies the tensor palati and tensor palati and tensor tympani. So tensor palati and tensor tympani are supplied by the trunk of the mandibular nerve through the nerve to medial pterygoid. Just remember this. It's not a direct branch. It's through the nerve to medial pterygoid. This all fine things do come in the exam. You have to be very clear about it. So in other words, all these muscles are supplied by the mandibular nerve because all these muscles are derived from the first pharyngeal arch. First pharyngeal arch. So muscles in the first pharyngeal arch, any guesses? Number one are the muscles of mastication, the masseter, the temporalis, the medial, and the lateral pterygoid. Yes, 4 muscles of mastication, 2 more muscles, one in the ear, one in the palate, tensor palati, tensor tympani, and 2 more muscles, one is the mylohyoid and the anterior belly of digastric. mylohyoid, and the anterior belly of digastric. So these are the muscles derived from the first phalangeal arch. So look, bacho, there are so many things that we are discussing in a small period of time, right? That's just a quick brushing of the topics. Excellent, very good. Here we go. We'll answer this. The defect in development of which of the following structures would result in clinical condition shown below? Any guesses? So what is this clinical condition? You just tell me what is this clinical condition first. What is this clinical condition? Left sixth arch. That's correct. What is this clinical condition, bacha? This is a patent ductus arteriosus. Patent ductus arteriosus. Excellent. Drug of choice. Very good. That's a patent ductus arteriosus. And this is due to left sixth arch. Okay, left sixth arch artery. In fetal life, there's a communication between fetal life. Okay, I'll just make this. That's sixth arch artery. I'll just make this for you. So, bachcho, a quick go through. A very, very important MCQ for you. So, this is the umbilicus. But this is umbilicus. Tell me what are the contents of umbilical cord. Contents of umbilical cord is one umbilical artery and two umbilical veins. No, sorry. One umbilical vein and two umbilical artery. Which is the vein left? Left is left. So that's the left umbilical vein and two umbilical arteries. The left umbilical vein goes and joins with. Okay, I'll just make it like this for you. Look, something very important. Something very important. That's the liver, that's the portal vein here. So the left umbilical vein goes and joins with the left branch of portal vein. The left umbilical vein goes and joins with the left branch of portal vein. From the left branch of portal vein, this is pure blood. The left umbilical vein is carrying pure blood. It goes to the left branch of portal vein. From the portal vein, it will go to the liver. Suppose if the blood goes to the liver, all this blood will be used by the liver for its metabolism. The entire blood should not go to the liver, correct? There's a bypass here. There's a bypass from the left branch of portal vein to the IVC. Can anyone tell me what is this? From the left branch of portal vein to the IVC, there's a bypass. What is this bypass known as? This bypass is known as the ductus venosus. Ductus venosus. So, left umbilical vein brings the blood from the placenta. That's pure blood. This pure blood comes to the left branch of portal vein. From the left branch of portal vein, the blood will go to the liver. But there has to be a bypass. Otherwise, the liver will use all this pure blood. So, there's a bypass to the IVC. That bypass is known as the ductus venosus. Now, from the IVC, the blood goes to the right atrium. From the right atrium, the blood directly goes to the left atrium through the foramen ovale. Foramen ovale, right? It goes to the left atrium through the foramen ovale. Left atrium to the left ventricle to the aorta. Aorta divides into common iliacs. Common iliacs divides into an external iliac and internal iliac. External and internal. And from the internal iliac, we get two arteries here. These are the umbilical arteries. Okay, these are the umbilical arteries which begins from the internal iliac, which goes towards the umbilicus. Now, where are the internal iliacs located? That's in the pelvis. Correct, bacha? That's in the pelvis. And from the pelvis, this umbilical arteries will begin. They're going towards the umbilicus. On the way comes the urinary bladder. That's the urinary bladder. So one artery goes from this side, one artery goes from this side. They go on either sides of the bladder towards the umbilicus, right? Now, suppose from the right atrium, if the blood goes to the right ventricle, from the right ventricle, it will go to the pulmonary trunk. And from the pulmonary trunk, it will go to the lungs, right? But the lungs are not functioning. So the blood should not go to the lungs. Now, my dear children, there's a bypass here. There's a bypass from the pulmonary artery to the aorta. And this is what we call as the ductus arteriosus. Ductus arteriosus. So what have I drawn for you? Can anyone tell me what is this thing that I've drawn for you? Come on, bacho. In a nutshell, tell me what is this structure that I've drawn for you. A very important MCQ. Yes, drug of choice. Bolo. Abir Mani. This is fetal circulation. Very good. This is fetal circulation. Excellent. That's a fetal circulation. Right. So now you tell me, I'll just label this for you. This is the left umbilical vein. This is the left umbilical vein. Just 1 minute. This battery would go now. Okay. That's the left umbilical vein. This is the ductus venosus. This is the left umbilical vein. That's the ductus venosus. Fine. So now you tell me what happens after birth. After birth, this is gone. The left umbilical vein is gone, and this becomes the ligamentum teres. This becomes the ligamentum teres. Obliterated left umbilical vein becomes the ligamentum teres. That's number 1. The ductus venosus becomes the ligamentum venosum. Ligamentum venosum, right? The foramen ovale becomes what? Fossa ovalis. Fossa ovalis. The ductus arteriosus becomes ligamentum arteriosum. Ligamentum arteriosum. And now you tell me, my dear children, this is the umbilical arteries. This part of the umbilical arteries from the bladder to the umbilicus obliterates off. This part of the umbilical artery from the bladder to the umbilicus obliterates off. This is what we call as the obliterated umbilical artery, and this is now known as the medial umbilical ligament. Medial umbilical ligament, right? Very good, very good. Now it's clear. And the same medial umbilical ligament or the obliterated umbilical artery which was dividing the Hasselbalch's triangle into 2 parts, a medial direct and a lateral direct inguinal hernia. I hope you will be able to correlate now. Okay, and this is the non-obliterated part of umbilical artery, and this non-obliterated part of umbilical artery now begins from the internal iliac, and now it comes to supply the bladder, and this is now what we call as the superior vesical artery, right? So this becomes the superior vesical artery, a very important MCQ bacha. So superior vesical artery is the non-obliterated part of umbilical artery. Perfect. Superior vesical artery is the non-obliterated part of umbilical artery, and the obliterated part of umbilical artery becomes the medial umbilical ligament. Should be very clear. That's fetal circulation for you, my dear children. Fine. Very nice, very nice. And see, and one more thing, can you tell me? Yeah, and a bladder. From the apex of the bladder, look, from the apex of the bladder to the umbilicus, there's something here in fetal life. From the apex of the bladder, yes, very good, very nice, bacha. You all are answering and you all are understanding. I'm very happy. Look, ये ना अपना bladder है. This is our urinary bladder. In fetal life, from the urinary bladder to the umbilicus, there's a communication. Can anyone tell me what is this communication known as? This is the urachus, right? Or this is what we call as the allantois. The allantois or the urachus connects the urinary bladder to the umbilicus in fetal life. After birth, this gets obliterated off, and this is what we call as, yes, any guesses? This is what we call as the median umbilical ligament. Be very clear. So what is median umbilical ligament? It's the obliterated urachus or allantois. Excellent. And what is medial umbilical ligament? It's the obliterated umbilical artery. Very good. And if this urachus does not obliterate, normally after birth this urachus is going to obliterate, forms a median umbilical ligament. Suppose if this urachus does not obliterate, the child will be passing urine through the umbilicus, right? The child will be passing urine through the umbilicus, and this is what we call as a urinary fistula, or this is what we call as a weeping umbilicus. This was an MCQ, bacha. Crying umbilicus or weeping umbilicus is due to persistence of urachus. Weeping umbilicus or crying umbilicus. Persistence of urachus, urinary fistula. Very good, very good, very good. Okay, fine. No, so I'll proceed to the next MCQ. Answer this. The direct inguinal hernia is due to weakness of which of the following? Which of the following? Answer this. This is an easy MCQ. You must be knowing this. Come on, Bachcho, answer this. That was a very important MCQ. See, I'm trying to focus on the important topics. Otherwise, the other topics you might be knowing. So, topics which you may be finding it difficult. Shall I answer this? Direct inguinal hernia. An indirect inguinal hernia is normally due to persistence of processus vaginalis. A direct inguinal hernia is due to weakness of the muscles. So, which is this? Conjoint tendon. Right? Weakness of conjoint tendon. Right? Okay, I'll just draw something for you. Okay, so that's weakness of conjoint tendon. So this is a conjoint tendon here. Conjoint tendon क्या होता है? It's the internal oblique and transverse abdominis. Yes. Conjoint tendon is internal oblique and transverse abdominis. I'll draw something else for you. Just have a look at this. That's the anterior superior iliac spine. That's the pubic symphysis. This is the obturator foramen. That's the pubic tubercle. What is this, bacha? Can anyone tell me what is this? Extending from the anterior superior iliac spine to the pubic tubercle. What is this? Anterior superior iliac spine to the pubic tubercle. This is the inguinal ligament. The inguinal ligament is also known as Popart's. Inguinal ligament is also known as the Popart's ligament. Now this inguinal ligament is going to turn. Now this inguinal ligament is going to turn like this. What is this turn known as? Yes, what is this turn known as? From the anterior superior iliac spine, this inguinal ligament is going to turn like this, and this turn is known as the lacunar ligament, right? This turning of the inguinal ligament is known as the lacunar ligament. Lacunar ligament is also known as Gimbernett's ligament. Just remember all this. So inguinal ligament, if I make it like this, inguinal ligament turns like this. That's the lacunar ligament. And now the lacunar ligament, bacha, is going backside here. What is this part of the pubis? That's the pecten pubis. That's the pecten pubis. And this ligament is now known as the pectinate ligament. Pectinate ligament is also known as Cooper's ligament. This is also known as Cooper's ligament, right? So that's the inguinal ligament, that's the lacunar ligament, that's the pectinate ligament, which is going behind. What do all this forms boundary of? Can anyone tell me? All this are going to form boundaries of something. All this are going to form boundaries of something. Answer this you should know, my dear children. This you should know. Anteriorly is the inguinal ligament, medially is the lacunar ligament, posteriorly is the pectinate ligament, and laterally is the septum separating it from the femoral vein. What is the structure that we have drawn? Drug of choice, what is that? That's the femoral ring, my dear children. This is the femoral ring. Just remember the boundaries of femoral ring. This you should know. So what are the boundaries of femoral ring? Anteriorly, it's the inguinal ligament. Yes. Femoral sheath nahi bacha. Arshi, it's not femoral sheath bacha. It's the femoral ring. Femoral sheath ka medial compartment. Femoral sheath ka medial compartment is known as the femoral ring, right? So what are the boundaries of femoral ring? Whose anterior inguinal ligament, whose medial, that's the lacunar ligament, whose posterior, that's the pectinate ligament, and whose laterally is the septum which separates it from the femoral vein. This femoral ring is closed by a lymph node. Can anyone tell me what is this lymph node known as? The femoral ring is closed by a lymph node. That's the lymph node of Cloquet or Rosenmuller. Lymph node of Cloquet or Rosenmuller. Excellent, very good. And what is this lymph node drain? That's a very, very, very important MCQ. What is this lymph node drain? The lymph node of Cloquet or Rosenmuller. What is this drain? Very good, Jasmine. Yes, I mean, you know all these things. My job is just to, bring things together and make what your concepts are there. Just make it clear. Yes, this lymph node of Cloquet or Rosenmuller drains the glans penis and the glans clitoris. But this MCQ is very important. Just remember, the lymph node of Cloquet or Rosenmuller drains the glans penis or the glans clitoris. Huh? वो क्या है? That's a deep inguinal lymph node है ना बच्चा? That's a deep inguinal lymph node. So the glans penis or the glans clitoris is drained by the deep inguinal lymph node. That's the lymph node of Cloquet. अगर MCQ आता है, if the MCQ comes, the penis or the clitoris drains into, your answer is superficial inguinal lymph node. Penis or clitoris drains into superficial inguinal lymph node. Remember, bacha, if the MCQ is glans penis, glans clitoris drains into deep inguinal lymph node, that's the lymph node of Cloquet. Hope I'm very, very clear to all of you, bacha. Yes. So now this femoral ring is wider in whom? The femoral ring is wider in females. This was an MCQ asked in the INICT. Femoral ring is wider in females. Why? Because of the wider pelvis and the smaller size of blood vessels. Okay, so femoral hernia is more common in females. Because the femoral ring is wider, so femoral hernia is more common in females. अब अगर femoral hernia होता है, if there's a femoral hernia, you have to cut something. You have to make the femoral ring wider. You have to cut the lacunar ligament. We make the femoral ring wider. We push the hernia up. We put a mesh. Fine, very good. But occasionally there's someone here. Bacha, I want you to identify who's this. A very, very important MCQ. क्या बच्चा scrotum का क्या? Scrotum drains into superficial inguinal. External genitals except the glans penis and glans clitoris. Scrotum, labia majora drains into superficial inguinal lymph nodes, bacha. So how is that sentence? The external genitals drains into the superficial inguinal lymph nodes except the glans penis and the glans clitoris drains into the deep inguinal lymph nodes. ऐसे याद रखना. That's how the statement is. Clear, बच्चों? Okay. Oh yes, very good, Dr. Arish. Yes, this is the abnormal obturator artery. That's the abnormal obturator artery, and this abnormal obturator artery lies on the lacunar ligament. And if we cut this lacunar ligament, we have to be very careful about this abnormal obturator artery. Otherwise, this would lead to hemorrhage. Perfect. So that is about the femoral ring, the femoral sheath. Now who's there in the lateral compartment of femoral sheath? Bacha, that's the femoral artery plus the femoral branch of genitofemoral nerve. What's in the intermediate compartment? That's the femoral vein, and the medial compartment is the femoral canal, right? The lateral compartment is femoral artery and the genital branch of, I'm so sorry, and that's a femoral branch of genitofemoral nerve. The genital branch of genitofemoral nerve enters the spermatic cord. Spermatic. Perfect. Very good, very good. Yes, coming to the last MCQ, bachcho, last MCQ. Chalo, answer this, my dear children. Which of the following is the adult derivative of the mark structure? I just told you this. Just the last MCQ, we wind up with this. I just told you this. What is this pointed structure, bacha? What is this pointed structure? This is the urachus. That's the urachus. The pointed structure is the urachus or the allantois. The answer is median umbilical ligament. I'm so happy. Very good. That's the median umbilical ligament. What is This is, so I'll just write this down as the obliterated urachus. If this does not obliterate, that is weeping umbilicus, correct? Medial umbilical ligament, that's the obliterated umbilical artery. That's the obliterated umbilical artery, that's a medial umbilical ligament. Ligamentum teres, you know, ligamentum teres hepatis, you know, that's present in the falciform ligament. Meckel's diverticulum. What is this? Meckel's diverticulum. See, what is this? That's a yolk sac, right? This is the yolk sac. In fetal life, the midgut is going to communicate with the umbilicus. The midgut is going to communicate with the umbilicus through the vitelline duct. Vitelline duct. Vitelline duct. The midgut is going to communicate with the umbilicus through the vitelline duct. Right? Later on, this vitelline duct disappears. It is also known as the vitellointestinal duct. Normally, after birth, this vitelline duct obliterates off. If this entire vitelline duct is going to persist, this is the vitelline duct, bacha. Look at this. This is the vitelline duct. I'm drawing this. That's a midgut. Midgut is communicating with the yolk sac with the vitelline duct. Baad mein what happens is this yolk sac is going to obliterate off. Yolk sac goes off. The midgut communicates with the umbilicus through vitelline duct. If this vitelline duct does not obliterate, it results in a fecal fistula. Fecal fistula. Normally, what happens? The entire vitelline duct obliterates. If it does not obliterate, that's fecal fistula. Most of the time, the distal part of the vitelline duct obliterates, and the proximal persistent part of vitelline duct, proximal persistent part of vitelline duct is known as Meckel's diverticulum. Okay, right, Anna? Normally, the entire vitelline duct goes off. If this vitelline duct, the distal part obliterates and the proximal part remains, the proximal persistent part of vitelline duct is known as Meckel's diverticulum, right? It mimics appendicitis. So when we remove this appendix, the surgeon tries to see the anti-mesenteric border of the small intestine 2 feet from the ileocecal junction. In 2% of the patients, 2 inches long is this Meckel's diverticulum, and if there's a Meckel's diverticulum, as a surgeon, you're going to remove this Meckel's diverticulum because in future it might mimic appendicitis. Okay, so that's the proximal persistent part of vitelline duct is Meckel's diverticulum. Perfect, bacha. Is this clear to all of you? Just one slide. Have a look at this. This is the falciform ligament. That's the falciform ligament. That's the ligamentum teres. That's the ligamentum teres. What is this number 1? What is this number 2? And okay, so that number 1 is the median umbilical ligament. Number 2 is the medial umbilical ligament. This is a view from inside. ये view क्या है? कहाँ से देख रहे हो? Where are you looking this from? This is the anterior abdominal wall from inside. You're looking at the anterior abdominal wall from inside the abdomen, right? So this is the falciform ligament. Yeah, na, this is the falciform ligament. In the falciform ligament, what do we get? Ligamentum teres, right? That's a median umbilical ligament. ये दिख रहा है? This is the bladder, है ना बच्चा? This is the bladder. So that's the median umbilical ligament. On either sides of the median umbilical ligament, this is the medial umbilical ligament. Medial umbilical. Fine, bacha. I hope things are clear to all of you. This PDF of the lecture will be uploaded on PW Med at Telegram channel. My dear children, I hope this lecture is clear to all of you. I enjoyed this lecture because you are very, very interactive, and I'm definitely sure you'll get very good marks, very good results in your exam because you're very clear in anatomy. The basic sciences has to be very clear. So the clinical subjects becomes easy to understand. Thank you, my dear children. Thank you for this patient listening. I hope you have enjoyed the lecture. In case of doubts, do get back. Okay, I'll answer it. Thank you. Thank you once again. Thank you. We'll stop here.